Welcome to Getting Better with Dr. Adam. Dr. Adam Silberstein is a clinical psychologist who has been working in the field since 1993. With a broad range of clinical experience, including state psychiatric hospitals, adolescent residential treatment with a trauma focus, the Department of Corrections, and in the addiction treatment arena. He is currently in private practice and is the clinical director and co-founder of Westside Treatment, a young adult dual diagnosis treatment facility in West LA. This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.
I just met with Dr. Elliot Weiner, and he is the co-founder of New York CBT. It's a group private practice in Manhattan. He specializes in cognitive behavioral therapy and dialectical behavior therapy. He's an expert in the treatment of post-traumatic stress disorders, as well as other issues related to trauma. Well-trained, Ph.D. from Fordham. He did his residency at the VA Medical Center in Hawaii, in Honolulu. And, you know, I like to say that stuff just because that's just the fluff. But what I really like in speaking to people is down-to-earth conversation. And Dr. Weiner did a fabulous job, you know, really informing how trauma is so impactful to some people and could really, really cause an individual to have chronic suffering and terrible distress, and how there's actually a true proven method that he employs of how to work with people and help them get better and address and confront these terrible fears that come from trauma, and to confront them in a way which is empowering and also helps them to cope and live fuller and healthier lives. So enjoy it. I hope you get a lot out of it. Hello, I am Adam Silberstein. You are with me, joining Dr. Elliot Weiner on Getting Better with Dr. Adam. And welcome, Elliot.
Thank you. Good to be here.
And I'm so happy to have an expert in the word expert is so cool, meaning this is Dr. Weiner is someone who is really, really trained in PTSD, trauma, and dialectical behavior therapy, and grateful to have you.
Thank you.
So I want to start off just sort of my reaction to the word trauma, and it's almost like the word addiction. And addiction is a thing. It's a real thing. When you watch alcoholics and they can't stop drinking, drug addicts not being able to stop drugs, and to watch the demise in active addiction is so sad. Homes are wrecked, jobs are lost, people are hurt. And what to me has happened with that word is, I can be addicted to a certain type of Kleenex. I can be addicted to gum, and it's over time traveled to anything that I do a lot of, and it feels like I can't stop. And it's in some ways lost its potency to me. What does it mean to me? And to be an addict is so troubling. And I want to just start the conversation with you on a question I have, which is, over the years, I've watched the word trauma turn into a word that describes any past experience that I have that's painful for me and still lives in me. And I just wanted you to touch on, what does the word, from your seat in training and in practice, what is the word trauma? How should we be receiving the word trauma?
Yeah, it's a really interesting question, because I think it ends up getting used in several different ways. So like you said, people will use it to refer to anything painful or unpleasant that they experienced, and even more extreme than that, when people will talk about like PTSD, which is a disorder that has a whole definition, and people will say like, yeah, I have PTSD about this, and they mean it about something that they're sort of just like throwing it out there.
Oh, so you're saying it
So
extends to PTSD too? It's not just the word trauma. It's like, oh my God, I just had a really horrible test. I have PTSD.
Exactly. Things like that will come up, or like, oh, I had this really uncomfortable date and now I have like PTSD from this date. And they don't mean that something traumatic happened on the date. They just mean it was a bad date. But when it comes to the word trauma itself, I think, like you said, there's that way that it has become sort of just used more generally. And then there is, I think, leaving that aside, there's a really interesting question in terms of like the textbook definition of trauma, which is really limited. The textbook definition of trauma is basically limited to death and serious injury and sexual violence. And then there are all kinds of other types of experiences that might be experienced the same way, meaning they might lead to a lot of the same types of emotional consequences, but that don't fit that type of narrow definition.
So hold on. When you're saying textbook definition, are you talking about the psychiatric textbook definition?
Yeah, exactly.
So death, sexual assault, and what was the third one?
Basically serious injury. So like actual death, or like the threat of death or serious injury. So if I get into a really bad car accident where I could have died, or I had a serious injury, like that would be considered, according to like the psychiatric diagnostic criteria, that would be considered trauma.
Right. And in some ways, what you're saying, I think, is that there's a limitation, even though I can have distress, right? By the textbook definition, if it wasn't a threat or a perceived threat, right, then, or it wasn't death, or it wasn't sexual assault, then I'm kind of, out of the definition.
Exactly. And there's really interesting research looking at basically, can people meet all the other criteria for PTSD, even if they didn't have that specific type of experience? So there are numbers of people, I think smaller, relatively speaking, but who otherwise would meet criteria for PTSD following like discovering that their partner has been unfaithful to them, or following a miscarriage or an abortion, things like that, which if we go back to just thinking about like the word trauma more generally, can definitely be traumatic experiences, can be extremely painful experiences. But according to that like textbook definition, we would never be able to say that they have PTSD because the textbook draws a line. And the really interesting thing with the textbook definition is that it changes every time they come out with like a new version of those diagnostic criteria. So every 10, 20 years or whatever it is, there will be a new definition of like what now we can say constitutes trauma. So there's a whole bunch of different factors that can play into that too, which probably kind of muddles the picture.
So for the sake of this discussion, and without we're not conducting any research here, we're just having what's sensible, right? It's sensible to me, right? And I'm hearing it this way, that if someone has a miscarriage, or if someone discovers infidelity, right, that they could be devastated. And to extend the word trauma when someone's devastated and in crisis and has ongoing sort of recurring thoughts or avoidance of situations that have to do with that, whatever it looks like. If they're in a lot of pain, suffice it to say, from something, right? Wouldn't it be reasonable to say, hey, that's traumatic?
Yeah, I think so, right? If we would say it's traumatic, if we would, say that this person has been traumatized by this experience, then I think that makes a lot of sense. Textbooks aside, I think that where, that other definition, or not even definition, that other usage comes in is when somebody refers to just something uncomfortable or painful, where they're not necessarily traumatized by it, but they're still using that same word.
Yes. So we're discerning right here. It could be used light and it could be used in a way that packs heat. And when it packs heat, so to educate us, and when somebody walks in and you're like, oh my God, that, empathic psychologist you says, oh my God, that's some trauma, right? How do they present? What is it like to be them?
Yeah, I think that the real question is how it's impacting the person internally. I think that that's far more important than like what the actual event was. So someone who we would say has been traumatized, let's say, or who experienced a traumatic event. I think that the idea that we're trying to capture is that this is really, it's kind of like always hovering in the background, that it's really significantly impacted their lives. And so, it might be that it's always there, that they are, pretty frequently thinking about it, having memories pop up of that thing that happened, or thoughts about that thing that happened, that they are considering traumatic. So it could be that just across the course of their day, things come up and remind them of it. It could be that when they lay down to sleep, thoughts pop into their mind, or that they might even have, bad dreams about it. It could be that when something reminds them of it, it brings up really strong feelings, whether it's sadness or fear or anger or guilt or shame or whatever it may be, depending on the specific experience and the specific person. But the idea is that it's kind of it's the lens through which they're seeing the world, that it's sort of always there, and it affects how they experience, if not literally everything, a lot of things. And then that in and of itself has other consequences, right? If that's constantly going on, then you might take steps to try and avoid that, right? To not think about that, or to not have to face things that might make you think about it or feel those feelings. And so people will often go to great lengths to avoid those things, and to try and steer clear of it, and also to do things to help themselves feel better. And so that often can get into other types of problematic behaviors, like you mentioned, addiction. So sometimes people will do things that are, more self-destructive or self-sabotaging, whether, substance use issues or self-harm, or on the more extreme end, suicidal behavior and things like that, because the emotions are so painful and the memories are so painful that they just want an escape or a release.
So the recurring thoughts are they're just, like it or not, they're, for the traumatized individual, they're on this person's radar, and like it or not, here they are. I'm going to go to sleep. Here they come. I'm going to have a dream. Potentially, here they come. I'm going to walk around, Manhattan where you are. That building reminds me of it. And it's so painful, and it's so much resources dedicated to managing or coping with it, or getting relief from it, potentially. And I just want to go back to something I hear often, especially in the world of, addiction treatment, that there's some sort of, when I hear the word trauma there's an assumption, and I know this is my take on it. There's an assumption that if we just dig deep and we unearth something, let's say I talk about a death, and I kind of have I'm matter of fact about it, and I don't have, it's not on my mind. It's not on my mind at all. I go to the cemetery. I'm like, okay, I see the tombstone, and nothing's coming up. And it was my dad. I lost him when he was 10. And I go to the tombstones. Nothing's happening. I don't really think about it. Somehow, I think there's a position that if I just connect enough, right, I'm going to address the quote unquote trauma, right? If I just can unpack enough and dig deep enough, even though I'm not reporting any distress about it, I get a report about somebody's history, right? I see that there's this experience when the person's 10 years old, and I say, it must be that. Let's travel there, because when we unearth it, there's going to be a good amount of pain release, right? And this person is going to integrate better. You're not talking about that.
That could be, that certainly can happen. I don't want to deny that can happen, but no, I'm not generally talking about that. I guess I subscribe more to the school of thought that if it is significant, that we probably can see it, not necessarily like immediately when the person sits down and starts talking to us, but that it's probably a little bit more evident. And the idea that you experienced something terrible doesn't necessarily mean that it's been traumatizing for you. So you give the example of like losing a loved one or a death. Plenty of people experience that, and it isn't traumatic. It's they grieve for it, and there might be sadness that comes up, or grief that comes up even years later when they're reminded of it, but that doesn't necessarily mean it's constantly hovering there and impacting their day-to-day life in that same kind of way. All of those examples that we were talking about before of trauma, the research on how much people in the general kind of population experience traumatic events typically shows that somewhere in the ballpark of like 90% of people at some point in their lives will experience something that could be considered a traumatic event. But that doesn't mean that 90% of us are internally experiencing things as traumatizing. And so that's really where I think the important distinction comes in. There's the event itself, but right, one person could get into a terrible car accident and walk away and not just physically be okay, but also emotionally not be too affected by it. And another person could never get in a car again and could be terrified every time they hear a car go by, and it can become something that really impacts their life on a more kind of constant basis.
And what I hear is what I hear also is that there's therapeutic value in perhaps unpacking and addressing past issues, right? And it's not like a bad move, right? But it's very, very, very different than a burdened experience of recurring thoughts and emotions that have to do with the traumatic event. It's not. Hear me right. I'm not saying it's a bad move to pursue past events that may have caused problems for an individual in a therapeutic context. But what we're talking about here specifically is of the people who have either by definition traumatic event or an extended definition that we gave, right? It's about how they're experiencing distress and what their internal life looks like, i.e. I suffer, right? I suffer and I avoid. So that's a good place for me to move on to the next piece of the discussion is, so when they come to Dr. Elliot Weiner, and when you get to the place and you realize that, oh my God, this person's suffering, right? And is in distress. What does the distress look like?
It can look very different. So I don't think that, any two people look exactly the same. But I would say the thing that really comes to mind for me is that these experiences, whether it's a single experience or whether it's a series of, multiple experiences like, repeated abuse or having been in some kind of abusive relationship or something like that, I think a big part of it is that those experiences have come to be part of like the defining features of that person's life, that person's emotional life. And so often those are the things that they want to talk about, that they want to figure out how to deal with. In a bit of a paradoxical sense, often people basically think like, well, this thing happened and I can't undo it, so there's nothing to do about it. But by the same token, I want to deal with it. I want to address it. And obviously, treatment for that, therapy for that we can't go back in time. We can't undo that. So it becomes more a question of how do we try and reduce some of the suffering that this experience has caused for you? How do we try and allow you to move forward in your life despite this experience and with this experience as part of your history, rather than, get you to be as though this thing had never happened? Because of course that's not necessarily possible.
So nobody can come into your office, and obviously you can never take away the event. So if you can't take away the event and you're working on coping, what does it look like? What is the treatment? How do you reduce symptoms? How do people get better?
So I think there's two components to it, two areas, I guess, that we focus on. One of them is really focused on the avoidance. I guess really broadly speaking, I would say it focuses on like behavior. So what the person does. So, right, if a person in response to this trauma spends a lot of effort and time trying to not think about it, trying to not be reminded of it, that's often what maintains the difficulty. And actually part of what causes the difficulty isn't necessarily just the event, right? If I told you I got into a terrible car accident yesterday and I really don't want to drive today and I had a nightmare about it last night, you would say like, yeah, that makes perfect sense. You had a really bad car accident yesterday. We wouldn't say that that person, has PTSD the day after the event. So really the issue is often what is keeping these reactions around, right? If it's 2 years after the car accident and I'm still having nightmares about it and I'm, avoiding driving in cars and everything like that. So then that's when we would start to have, well, not 2 years later, we would start to have this conversation, but it's when it lasts that we start to have this conversation. So one big focus is how do we address that avoidance? Basically, how do we try and allow this person to not feel the need to not think about these things, not be reminded of this experience, to not ever see or talk about things that might relate to it. And the reason that that's so important is that avoidance is a losing battle, right? Like we can't not think about significant experiences from our lives. And paradoxically, the more effort we put into not thinking about something, the more likely we are to think about it. And the other thing is that the more we avoid in our real lives, in our day-to-day lives, the narrower our lives become. So if I avoid anything that reminds me of this experience, then that is going to prevent me from doing a lot of things that might give my life meaning and satisfaction. And so one big thing that we focus on is basically how do we get this person to decrease their avoidance, to do things that they haven't been avoiding, to essentially not feel the need to let that fear guide their lives. And through that, what they typically learn is that they can handle the emotions that come up if they are reminded of the trauma. They can do the things that might bring it up. And that over time becomes easier and easier. And again, sort of paradoxically, the less effort I spend trying to not think about this thing, often the less I actually end up thinking about it.
It's so interesting.
Words,
It's so interesting to me. If I say like, hey audience, don't think about the pink elephant, don't do it, right? Like this image could come up of, it's very hard to not think about. If I'm instructed, don't you dare think about it, I'm going to think about it. And this idea that I could just not think about things, I see it so often. Like, I don't want to think about it. I don't want to talk about it. And what you're saying is, which makes sense to me, is the more effort we put into not doing something, not only do our worlds get smaller, but the harder it is to pull off.
Yeah, and it makes sense, of course, right? Like it's painful to think about these things and it's painful to remember them. And so there's a reason that we don't want to, right? There's a reason I don't touch a hot stove because it's going to be painful. The difference is that when it comes to trauma, it's something from the past, and the past isn't dangerous the way that the hot stove in the present tense is. And so that's a big part of the issue when it comes to dealing with trauma, is that we're reacting to something that was dangerous and painful in the past as though we are in danger now. And so part of dealing with trauma is trying to address that. It's trying to help the person basically live in the present and respond to whatever the present involves, rather than having everything that they're doing kind of dictated by the past and by the traumatic experiences from the past.
So I'll throw out, you use the example of a terrible car accident. It's a year later. I won't get in a car. I won't drive a car. I've even extended this to I don't want to get in cars, right? I can't get anywhere. I walk everywhere. I'm missing family events. I feel bad about it. I come to you, help, right? I can't, anything car is making me uncomfortable, bringing me back to that terrible accident.
So you're asking what
so
I would
I'm
do,
saying from the avoidance, am I coming to your session? You're like, hey, let's go take a taxi in Manhattan. I mean, is that the move? Like, hey, let's just go get a taxi. You'll be fine.
It could be part of it. Yeah, in not so many words, that's definitely going to be a part of it. So if this is in response to some kind of traumatic event, part of what treatment might involve, there's a couple of different ways that we could do this, but sometimes what treatment involves is basically confronting the things that we are afraid of, and that's both the things in real life. So it could be, let's say, getting in cars, and it could also be confronting the memories, because again, if a very big part of what the person is avoiding is thinking about this thing that happened and remembering this thing that happened, so it might be, okay, we're going to come up with a list of things that you're avoiding in real life, and we're going to do those things. And we would start probably with something that's more manageable. So maybe we would go and sit on a bench by the side of the road and we would just watch the cars go by, if you've been avoiding even looking at cars. And then maybe we would have you be a passenger in a car, or, I don't know, play like a driving video game or something like that might bring up some of the emotions. And we would basically work our way up. This is a process that's called exposure therapy. And the idea is basically by exposing yourself to the thing that brings up the emotions, ultimately the emotions come down. Essentially, you learn that you can handle them and the fear goes down. And then aside from the real life stuff, there's also the memories. And so part of what we would also do is basically talk through the details of what happened, not in like a brief, superficial way where you might tell me just kind of generally what happened, but we would go through it. It's basically trying to do exposure to the event, but we can't go back in time to the past. So we're going to do it in your imagination. And so we would have you essentially relive it in the office, which sounds kind of cruel and sadistic. And there are a lot of people who aren't comfortable allowing lot of therapists who aren't comfortable doing this. And that said, it's also extremely effective. People usually find that they start to see a significant difference really quickly from it. And the idea is that they would basically be going through and describing in as much detail as they can remember everything that happened, as though it's happening right now in the present tense. And that, again, right, because you are staying with the emotions rather than avoiding them or escaping them rather than stopping as soon as it becomes uncomfortable, what you learn is, A, I can handle this, as opposed to I need to stop this, I need to escape from this. And also you learn to distinguish between the past and the present. You learn to recognize that that thing that happened has ended and it's over. Not to say that it wasn't, traumatizing and extremely significant in your life, but that doesn't necessarily mean that I need to act in the present as though I'm in danger now or as though that thing is about to happen again.
It's so interesting how traumatic. I mean, I also have been trained in exposure therapy, and it's so interesting to me, first of all, to watch the empowerment of the mastery and incremental, you don't just throw somebody right to the wolves, but these incremental building blocks of things that I didn't think I could face that I can, and the empowerment of, wow, I'm actually not freaking out, and this is great. But it's also interesting to me how powerful the traumatic memory, when it really imprints strong on so many sensory levels, right? It's so visceral and as if it's happening. So the emotion, for the audience, when you're they're terrified as you're going through this. It's not just, hey, let's walk through it. Your people can report terror as they're walking, having the courage to face this.
Mm-hmm. Yeah, absolutely. Nobody ever says to me, I really want to do exposure. People typically will say, like, okay, I'm willing to do it because I believe that it'll be helpful. Because, yeah, it can be terrifying. It can be emotionally overwhelming. And our emotions aren't dangerous, right? The situation, the experience in real time might have been dangerous, but remembering it isn't dangerous. And the emotions that thinking about it will bring up are not dangerous. And that's really part of what we're trying to help the person learn, is that they can handle remembering it. And again, paradoxically, the less afraid of remembering it you are, the less it's actually likely to pop into your mind, and the less intense the emotions will be when it does pop into your mind. Because when it pops in now, it's kind of like a flash of something terrifying, and it's just like, oh my God, I need to escape from this right this minute. As opposed to if it just pops up and it's just like, oh, there it is again, right? Like, not a happy memory. It never becomes a happy memory, but it's not one that is terrifying anymore.
So the more you face it, the paradox is that the less it bothers you and the less it recurs. I just have a question. I wonder for you, we can talk about elevators, we can talk about car accidents, we can talk about combat. Does sexual trauma have a different does it have a different flavor in that it's one thing to have a car accident, it's another thing to talk about a rape or a molest or something like that. Is it its own category to you?
Yes, but not, I think not in the way that you're asking, actually. So what I would say is, first of all, this relates to where our conversation started in terms of the word trauma and the nature of trauma. I would say probably more than 50% of the people that I've worked with on trauma-related issues have at some point raised the question of, like, why they're reacting this way, because other people have experienced more severe traumas. And I'll say that, like, in quotation marks, like, more severe. So someone might have a terrible car accident and say something like, but it's not like I was raped, or it's not like, I was shot or something like that. And no matter how serious a trauma you can think of, I have heard a person say, but it could have been worse. Why am I reacting this way? There are other people who experienced worse abuse or more times or over a longer period of time. So I do think there is a difference, but not necessarily specifically because of, like, sexual trauma versus something like a car accident or a natural disaster or something like that. I think that the bigger distinction often comes up because of the fact that that has something to do with other people. And this gets into the second way that that therapy works. So there's the exposure piece, but then the other piece is the way that trauma affects how we see the world, right? So if we go through a traumatic experience, it is almost inevitably going to kind of color the way that we see ourselves and other people and the world around us, right? If I thought that the world was generally a safe place and then something, terrifying happens, there's almost no way that I'm still going to think like, yeah, the world's still a safe place. And by the same token, if I think that I can trust other people, if I think I can trust my own judgment and my instincts, and then something happens, like getting sexually assaulted, let's say, right, then that's going to affect how I see myself. That's going to affect how I see other people. It is likely to affect how I operate in relationships. And so a very big part of how people get better in therapy working on trauma is by figuring out what are the ways that this affected how I see the world and other people and everything like that. And basically taking a step back and figuring out like, where have my thoughts or my beliefs about myself and about other people kind of, gone awry? Where have my thoughts or beliefs gotten maybe overly extreme to one side? And how can we try and recognize those thoughts or those beliefs and evaluate them and figure out what is more accurate? Maybe people can't all be trusted, but that doesn't necessarily mean that nobody can be trusted. And so going back to your question in terms of like how that impacts things, I think that the real difference is that something like that is liable to affect not just my feelings of like safety in the world, like a car accident maybe makes me afraid of dying, but it doesn't necessarily affect, it may not affect, sometimes it can, but it may not affect how I see other people and my relationships with other people and my ability to trust other people and everything like that. And I think that's where there's a really significant difference. And there's research backing that up. When you look at the rates of PTSD after different types of traumatic events, the rates tend to be higher after traumas that involve other people as opposed to after traumas that don't involve other people.
Because the extension of the impact of how I see the world and my relationship to the world, my safety in the world, is very different if there are one or more individuals involved, or if there are multiple events. So if I'm somebody who's had sexual assault multiple times by different people, right? I guess what you're saying, there's some sense of severity, because that really, not only do I have potential for a traumatic reaction that we're discuss symptoms down the road, but I'm also shaping my worldview about who people are and what they mean.
Yeah, exactly. There's this book from like the late 80s called Shattered Assumptions. And I've always liked that title because I think it really captures what happens, that the worldview that you have can be like completely shattered by the event, by the experience. And so that, of course, is going to, affect how you operate in the world if everything that you thought and everything that you believed has been altered. The other side of this is, of course, some people have terrible experiences from very early in their lives. And so for them, it may not be that their worldview has been shattered. It may be that they just from day one have had experiences that have taught them, for example, that people can't be trusted and that the world is a dangerous place. And so whether it's, a new thing that happens in, your 50s when you've had a whole life of not feeling that way, or something that was happening from when you were a child, part of what therapy would focus on is basically how I've made sense of these experiences and where my thoughts or my beliefs have been colored by them in a way that might not be entirely accurate, that might be more extreme, probably because my mind was trying to help me protect myself, but inadvertently went so far that it has led to me being overprotective, and I'm responding and avoiding based on like fear as opposed to, what's prudent and what really fits the facts.
So that leads me to my next sort of segue is so I have a person who's not just had a car accident, not to minimize the car accident, but has had multiple events and really, really shattered assumptions and mistrust, and is in a chronic state of distress, and comes to you and learns. And as you get to know this person, they self-harm for relief. They sometimes think that it would be better if I died, and may even pursue that. They may use drugs and so forth. They may be prone to anger outbursts, and there's so much going on. How do you, when you have a trauma in the midst of that, and you have all these other things, Dr. Elliot Weiner, there's a lot to do in a 15-minute session. There's a lot. Where do you begin?
Yeah, it's a really good question. Right, PTSD is enough, or trauma is enough, but then you add a bunch of other things on top of it. Like, how do we deal with all of this? So,
and how does the person, they don't even, and the person who's like a pinball bouncing from emotion to emotion, I don't even know if they have the language to say to you, hey, like, I'm really feeling emotional right now, and I know it's like they're in distress. So where do you begin?
Yeah, so I think you're raising the question of like, how do we prioritize in therapy what to focus on first, right? If a person is on the brink of making a suicide attempt and they want to focus on PTSD, I need to make sure that they're going to stay alive long enough for us to treat their PTSD, because I'm not going to be able to do that if they actually end their lives, between now and our next session.
Research we're not there yet of treating dead people.
Exactly, right? So we need to figure out basically, how can we ensure that you're going to stay alive? How can we ensure that you're going to be able to keep yourself safe? And so you threw a bunch of examples out there in terms of, whether it's substance use or whether it's self-harm or suicide. And, we can go on and on in terms of the types of things that people do in order to try and give themselves some like brief relief. But I think that the real question that will come up is basically, can we start PTSD treatment right away, or can we start trauma-focused treatment right away, or do we need to focus first on other things in order to help create enough of like a foundation of safety and emotional control and stability in order to do that, which of course is a bit of a paradox, because like chicken and egg, right? If the PTSD is what's making you want to hurt yourself, then how can I get you to not hurt yourself without treating the PTSD? And so one of the ways that we do that is within a type of therapy called DBT, or dialectical behavior therapy, which is, I could spend a lot of time talking about it, but the really brief version is it was a type of therapy that was initially developed for people who were chronically suicidal, often who had made multiple suicide attempts, who were doing things to harm themselves, like cutting themselves or burning themselves or things like that. And so often what we'll do if I'm working with someone who kind of fits what you were describing before, is we'll try and integrate the trauma-focused treatment into this DBT approach, where basically what we would be doing at first is trying to ensure that they have the tools to manage their emotions, that they have the tools to experience that distress without doing something to harm themselves or without ending their lives, because we know that that therapy is going to bring that up, right? Having you think about the traumatic experience is going to bring up more distress. So it's not just that we want to make sure that you don't hurt yourself at baseline. It's also that we are going to do things that are going to be difficult and that are going to, in all likelihood, bring up those urges if that's something that you already do. And so we need to make sure that we can safely do that, knowing that we'll be able to continue going through the process and that you'll be able to keep yourself safe through it.
So the wisdom of this is, I can't just throw you to the wolves. I have to give you some basic tools to walk through this. And I know that I'm going to be eliciting this, I'm going to be igniting some stuff here. And I know that we're going to need you to have some help. So can you give us an example of, let's say somebody cuts, and for the audience, cutting, I'll take an object and I'll purposely cut, and in some ways, in most ways, I would say I'm doing that because I'd rather feel that than other things. It's a form of relief, right? I'd rather feel that. It's focused. It's focused. It's limited to one spot, and I may get a lot of relief from it. So how do you? But as therapists, right, we're not pro cutting, right? We're not like, hey, go to, we don't look at that as a great strategy. So what would be an example of a DBT strategy in regards to cutting?
Yeah, so I would say there's the like surface level, like what are some things that we can do in the moment, right? If you're having the urge right this minute and it's really strong, what are some things that you can do just to get through this moment without cutting? And then there's the broader question of like, what exactly is it that's causing that urge to cut? Is there a particular emotion that you have trouble sitting with? Is there a particular thought that we need to address? Is there, a specific type of situation that tends to bring up that urge, like, conflict with your partner or something like that? So in the moment, right, like just the thing to help you get through that moment. The most straightforward thing that I think everybody on the planet does at some points, is that we can distract ourselves, right? So if I am having the urge to do something self-destructive or something that might harm, myself or my life, sometimes the most helpful thing is to figure out, what can I do that will help me get my mind off of the thing that's bringing up those emotions, that will help me kind of break contact with whatever that is that's bringing up the emotions, until the emotions come down, because we know that they will come down over time. They might go down and then come back up, of course, right? But it might be as simple as, I'm going to watch something on Netflix. I'm going to go watch a movie for the next 2 hours. And for the next 2 hours, if I can really focus on the movie, then I'll be able to give my mind a break from whatever those feelings are. And at that point, I may not feel such a strong urge to cut anymore, because we know that those urges they rise and they fall, right? They come and go, and they don't just stay constant, even though sometimes they feel like they're constant. They usually don't stay constant and at the same level of intensity. And so that would be one example, just something that we can do to get through the moment. More broadly, we might need to figure out, okay, like let's say the emotion that brought it up was sadness. We might need to work on your ability to tolerate sadness, your ability to sit with sadness. And so we might talk about what are things that you can do that would help you bring down the sadness, maybe, getting together with a friend or going for a run or something like that. Those would be things that could help like change the sadness or decrease it. But we also might work on what can help you just sit with it and tolerate it. So we would work on like mindfulness skills in order to just observe the sadness without judging it, without reacting to it, just simply sitting with it and experiencing it for what it is.
So in the people I see who really respond well to DBT, right? What I'm seeing is there are these strategies that just sort of they kick into gear of, oh, I'll either observe, and they have just little good tidbits of how to walk through discomfort. Can you give us an example of a classic DBT tip for coping with distress or anything uncomfortable? I hear them throw out things like "dear man," and and these aren't people who are responding well to very insight oriented deep talks. They like the strategic. I hear them teaching other patients in our facility sometimes these skills, like, oh, you just need "dear man."
Yeah, and Dear Man, for those who don't know, Dear Man is this acronym that we have in DBT for like how to ask for something that you want in a way that increases the likelihood that the other person agrees and gives into what you're asking for.
Although that makes sense in an addiction facility, so that's perfect. So they're learning how to get what they want in a good way.
Yeah, and I would argue honestly that I think that when we talk about like skills, like DBT skills, I think everybody on the planet uses these things or needs to use these things. I think that some of us just don't have like these terms and these acronyms for them, right? Like if you are an effective communicator, you're probably doing something that looks like that Dear Man thing. You just you picked it up along the way somehow, from your parents or from school or whatever it is, without anybody ever having to sit down and spell out for you, okay, first you're going to do this and second you're going to do that and everything like that. So I don't think that there's something unique about what those skills are as much as the question of, for whatever reason, this person never was taught these things or never learned these things along the way. So now we have to plug them in. So to go back to your question about like what can someone do, what would be like a stereotypical like DBT skill to help someone get through a difficult moment, I think the one that people most associated with DBT for a long time was the idea of like holding on to ice cubes. And so the idea there is kind of if you're having like strong urges to do something that might be self-destructive or to do something impulsive, whether it's, self-harm or suicide, whether it's having a drink, whether it's risky sexual behavior or impulsive spending or gambling or whatever it may be. The idea would be to basically like take a couple of ice cubes and like clutch them in your hands. And the idea is that the sensation is so intense that it becomes kind of difficult to focus on anything other than the feeling of the ice in your hands. And what's nice about it is that it can be pretty intense and sometimes even painful, but there's no actual damage that you're doing to yourself, right? You're not harming yourself in any way by holding an ice cube until it melts. And that's, one example of a way that you can try and help. It's in that family of like distractions that I was talking about before, but it's a way to help buy yourself some time when you might feel like you desperately need to do something right this second and you can't wait even 5 minutes.
Anything, including getting in a fight. Meaning it could be anything, meaning I just need to be present. I need to not get boiled up in whatever emotion I'm in. How do I distract myself? That's so you would say that's a classic DBT move.
Yeah, absolutely. I would be remiss if I left people thinking that DBT is all about just how do I distract myself and buy myself time. So there's 4 different like areas of skills that we focus on in DBT, and one of them is this question of just like how do I buy myself time? How do I get through this moment, this emotional crisis, without doing something that might give me some relief right now, but is going to cause problems for me longer term, or I'm going to regret longer term. So this is just one.
So
area.
One is impulse control. What's another area?
Another one, I would say the most important one, is generally what we call emotion regulation. So DBT focuses and kind of revolves around this idea of of regulating our emotions or managing our emotions. And the idea behind that is that often people that DBT is a good fit for are people who have trouble managing their emotions, kind of, across the emotional spectrum. So they, when they are down, they get really down. When they are anxious, they get really anxious. When they are, ashamed, they feel really ashamed. Not necessarily literally every single one of these things, but, the idea is that their emotional spectrum is wider. Their emotions get set off more easily and they feel them more intensely. So emotion regulation skills are all about that. It's basically, how do I, first of all, recognize what I'm feeling in the moment? How do I identify the emotion that I'm feeling? Because even being able to label the emotion and recognize kind of what it is that set it off and why I'm feeling it can help increase our control over it. We teach skills for trying to change those emotions. So if I'm feeling really depressed, what can I do to bring up my mood? Or if I'm feeling really anxious, what can I do in order to decrease my anxiety? And then we also teach skills for helping protect ourselves against our emotions becoming more intense or out of control. So what can I do kind of on the front end? What can I do on the preventative end so that I don't get as depressed, so that I don't get as anxious, so that I don't get as angry, things like that. So we want to both increase our ability to control our emotions, and we also want to increase our ability to sit with them, because the answer is not always, okay, how do I not feel this or not feel this as much, right? Part of life involves emotions, involves feeling our emotions, right? There are no human beings out there who just don't have emotions. And so if the answer is always, I need to not have these or not feel them as strongly, then we're kind of setting ourselves up for failure. So the other side of DBT is basically, what can I do in order to experience this emotion and sit with it and tolerate it and not necessarily need to do anything about it.
So, and to bring it back to trauma and the individuals who may benefit from this, right? It does, chicken or egg. They may have been individuals who are emotionally had these sort of extreme, broad emotions beforehand, but a trauma is in the story, and it can totally impact it. You give them the tools to cope with these emotions, and then ultimately they start to face the trauma, and they're backed up by these skill sets, these skilled techniques that you give them as you walk through the trauma. One of the questions that was raised is medication, as far as this experience, is medication, is it a helpful tool in the processing of the trauma, or in any way with the emotional dysregulation that you're describing? What would your stance be on the tool of psychiatric medication?
I think it certainly can be, and I will give the disclaimer that I'm not a psychiatrist or a psychiatric nurse practitioner, so it's not my focus, and I will limit how much I say about it because I don't want to speak out of turn. But what I will say just anecdotally from my experience is that I've certainly had plenty of people who really have found medications to be extremely helpful for them, whether in managing their emotions more broadly or in coping with symptoms of PTSD. And unfortunately, I've also had plenty of people who have tried, literally as many as dozens of medications and just really not found any relief from them, and who at the end of the day, what they needed was effective therapy rather than effective medication. So I think some of this just has to do with who the specific individual is and how they respond to medication.
So it's not from in the training and your background in residency that you did in trauma training. So it's more a question of, is medicine for a psychologist, right? And yes, we are not the prescribers, and we are not, this is not our area, we're the therapists, but we work often hand in hand with psychiatry. Is it a reflexive go-to move that medication specific to trauma will be helpful, or it's hit or miss in terms of protocol?
For me, it's not. I would say for me, it's not a reflexive go-to move. That might just be my bias personally. I'm sure there are other people who immediately would refer to a psychiatrist for medications. My general approach is, if the person is kind of ready and willing to try therapy without adding, without either starting medications or adding to the medications that they're already on, I always would love to see whether therapy alone is helpful for them, because I think most people would prefer to not have to take medications, whether just because they don't want to take medications or side effects. And so if we can achieve what we want to achieve without medications, then I would say that's great. That's a win. And that said, sometimes either the person really needs something more immediately, or sometimes we'll try the approach that we're taking in therapy for a few months and they really won't be seeing the benefit that they want to see, or there will be just something going on that is too intense right now for them to deal with without more immediate relief. And if that's the case, then I certainly will refer out to psychiatrists or nurse practitioners who can prescribe for them. I guess my approach is, if we start medications and therapy right now, then I'm not necessarily going to know, or you won't know, I should say, whether it was the medication or the therapy that was helpful. And although at the end of the day, what I want most is for you to feel better, and it doesn't necessarily matter which one it was that made you feel better. If we don't have clarity, then that might impact decisions that you make, for example, about whether to continue taking medications or whether to continue therapy, or things like that. And so if we can achieve that without having them both simultaneously, then that can be, I think, really helpful.
So I want to wrap up, but I want you to give me an example, obviously protecting confidentiality and what you can say of the type of case. We can even keep it general. The type of case where a situation where you were just blown away by how well this worked. From person coming in and person graduating, what you saw, that just was remarkable to you.
Yeah. I'll try and give an example without giving too much detail, given confidentiality and all of that.
It could be a type of case that, like, oh my.
Yeah, there are a handful of people that I have worked with who have experienced like chronic childhood sexual abuse, and who came in having made multiple suicide attempts and having histories of, let's say, alcohol abuse problems and things like that, as well as cutting, and who had PTSD, but also other things like, depression, let's say, and just generally having a lot of trouble like functioning in life and in relationships, and who I've seen basically go through this process and first and foremost increase their ability to keep themselves safe. So, stopping making suicide attempts, stopping cutting, ideally stopping drinking, let's say, but if not stopping, then at the very least gaining enough control over it to allow us to move forward with the trauma-focused treatment. And then going into the trauma treatment and therapy and going through that process that we were talking about before, of addressing the ways that this impacted their beliefs about the world, of engaging in those types of exposures that we were talking about, which when it comes to somebody who experienced chronic sexual abuse, a couple of the examples I'm thinking of involved like dating and having relationships and trying to be able to have sex with their partners without dissociating or having a flashback, and instead being able to be present, and just going through that whole process and being able to sort of alter the way that they saw themselves and the world around them and other people in a way that allowed them to really get back to, or either get back to the lives that they had been having, or get kind of on track toward the lives that they envisioned for themselves professionally and socially and things like that. And it's been really amazing seeing people like the people I'm describing get into, let's say, longer term relationships when previously they had only had like really brief flings that usually flamed out, and establish really satisfying careers and achieve a lot in their professions. And so it's really amazing being able to see how much of a difference this can make, which I think makes sense because, again, right, if trauma really upends the way that you see the world, and it's kind of always there in the background, then if we can effectively deal with it and allow someone to move forward in their lives, then it can totally change what their experience is like.
So that myopic world that you were describing, which is so colored by the belief of the world operates in a certain way, when you watch that change and you watch the person change their worldview as they face and confront their fears, they walk out a different person. Unbelievable. And I would imagine it's very rewarding to see the symptom reduction and to see people really get better. And just to close, if you could just, your practice is in Manhattan, and I know you're there. and your office is there, and you have a group practice. And if you can just give a little bit of information if somebody wants to get in touch with you, where they could find you and how they can reach you.
Yeah, absolutely. So the easiest way to find information is probably on our website, which is newyorkcbt.com. That's New York spelled out Newyork, and then C like cat, B like boy, T like Tom. You can email me directly at Elliot@newyorkcbt.com. That's ELLIOT. Or you can call us at 646-653-0933.
Thank you so much. What a wealth of information, down to earth and digestible, and you know what I really want to say? Doable, right? This is something that works. So great to have you on, and thank you so much.
Thank you for having me. Good to talk to you.
Good to talk to you.
Bye-bye.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there's an emergency, it is strongly recommended you seek treatment at your nearest emergency room.